Can you see my slides okay?
Yes.
Great.
Okay, thank you. All right, so I'm going to talk about the management of immunotherapy-related side effects. And also at the end, I'm going to have a couple of slides on the BRAF MET combination as well. So let me try to advance my slides.
Kelly, click on the slide first, and then it'll be able to advance, I think.
Okay, yeah, I think I just have multiple screens going on, so okay, let me just try to do this here. Sorry about that, just give me a minute. I'll just change my screens around. All right, can you still see my slides now?
Yes, we can still see the first slide.
Great. All right, so I have no disclosures. Our objectives today will be to understand the common side effects of immunotherapies, including reviewing and how to manage select immune checkpoint inhibitor toxicities. And at the end, we'll have the BRAF MET combination side effects to discuss. Just some general comments on the side effects. We like to identify them early. It's easier to treat and more effectively treat when we can identify early. We do need to exclude other causes, such as infectious causes or other exposures. Treat promptly, taper slowly if the corticosteroids are necessary, and we may need to withhold treatment either temporarily or sometimes permanently during the toxicity management. As you've already heard today, so here's some of our immunotherapies that we have approved. The ones we use in melanoma are the anti-CTLA-4 ipilimumab, and the anti-PD-1s nivolumab and pembrolizumab, and then also the anti-LAG-3 relatlimab, which is used in combination with nivolumab. The side effect profile of these drugs are all basically the same. It's an immune response against normal tissues. We just see them in different frequencies with the different treatments, which I'll get into in a little bit. So the side effects are immune mediated. Most of these are mild to moderate and reversible. Some of them can be permanent, like the endocrine abnormalities, but usually very manageable. Can be life-threatening rarely, which comes into play with how we like to jump on these quickly when we need to. The side effects can affect any part of the body. The more common ones that we see are rash or dermatitis, pneumonitis, inflammation of the lungs, some endocrine abnormalities like the thyroid, inflammation, hypophysitis, and then adrenal insufficiencies, as well as like enterocolitis and inflammation of the eye. So how these, we're trying to activate your immune system to go after the melanoma cells, but in doing that, we can also activate the immune response against normal cells as well, which can lead to inflammation and development of these side effects. The median time to onset can range from days into starting treatment to years. So some people can be on drug for almost 2 years and then develop a serious adverse event that needs treatment. So it can really occur at any point during treatment. This little graph you see on the bottom right, this one I think is from ipilimumab, but we do see most side effects in the first 12 weeks of treatment. But again, this can happen at any point. The most common immune-related adverse events, or IRAEs, as you'll see abbreviated in my slides, include rash, some fatigue, colitis, hepatitis, which is inflammation of the liver, not the usual viral hepatitis most people think of. This is an inflammatory response against the liver cells, pneumonitis, and endocrine abnormalities. The treatment depends on the severity of these symptoms and the grading. We use a grading system called the CTCAE. I have a slide shortly to show you, but we grade each side effect based on the CTCAE grading system. The general management when we need to intervene includes immunosuppression with corticosteroids. So most of these side effects are reversible with steroids. They do require prolonged steroid tapers, usually over about 4 to 6 weeks, and also may require multidisciplinary approach using other teams such as the dermatologist, the GI group, the pulmonary group. So we do consult other specialties when needed. Here are the different grades that we use for the immunotherapies and any side effects. A grade 1 is usually mild side effects, usually asymptomatic or very minimally affected. Intervention is not always needed, but sometimes like topical creams could be indicated. Grade 2 is more, a little bit more significant side effects, usually still pretty manageable, not that bothersome for a lot of people, but usually indicates some sort of treatments like Imodium for diarrhea or topical steroids. Grade 3 and 4 are the more significant side effects that generally require steroid use. So, sorry, this slide here is a summary of the frequency of side effects that we can see. This is across different clinical trials that were done with advanced melanoma. The first column is for Ipi-Nivo. So we do see more side effects in Ipi-Nivo combination compared to like Nivo or Pembro monotherapy. About 55% of patients have grade 3 to 4 side effects, which would require corticosteroid use. About a third of patients did have to discontinue treatment because of the side effects. Nivo and Pembro have fewer side effects or fewer grade 3 to 4 toxicities, about 10 to 15%, depending on the trial. And the combination Nivo-Rela is a little bit more frequent than the single agent Nivo or Pembro, but still less than the Nivo-Ipi. But about 20% of patients needed to go on systemic steroids for side effects. This graph here is showing on the left, you see the ipilimumab or anti-CTLA-4 type toxicities. We see a lot more GI side effects with Ipi, also more side effects in general compared to the single agent anti-PD-1s, which you see in the middle. So the first one I'm going to talk about specifically would be dermatitis or rash. This one is probably the second most common side effect that we see in the immunotherapies after fatigue. Grading is a little bit different with this. We use body surface area in addition to symptoms to grade rash. On the top right picture, you'll see kind of our standard maculopapular rash that can happen anywhere on the body. We see it pretty commonly on the trunk, the torso, or the sometimes in the extremities. Not always symptomatic, sometimes can be pretty itchy for some folks. The way we treat it is we do enroll other causes, like other drugs that might cause rash, like antibiotics, other exposures like poison ivy, etc. So getting a good history is important here, but this is pretty common. Mild grade 1, we can continue the the immune checkpoint inhibitors generally, use oral antihistamines or topical steroids if needed. For more severe side effects like grade 3 to grade 4, these do require holding treatment and treating with like corticosteroids like oral prednisone. So for some more severe reactions, we do tend to give IV steroids in the hospital if needed. That's pretty uncommon. Usually this responds really well to oral steroids when we do need to start it. And then after the rash improves to grade 1, so minor or no symptoms or better, then we taper the prednisone or the steroids over about 4 to 6 weeks. Diarrhea and colitis, we see this quite a bit with regimens with ipilimumab. Can still see it with the single agent PD-1s. Usually patients present with diarrhea or increased frequency of bowel movements. They can have abdominal pain and cramping, some nausea, vomiting. We don't usually see blood in the stools, but it can happen. Usually it's increasing stool frequency and loose stools. When people come to clinic with diarrhea on immunotherapy, we do get stool cultures. We want to rule out other causes of diarrhea, like bacterial, like C. diff, some viral infections that can cause diarrhea, or parasites. We do assess the severity of the colitis by the number of bowel movements per day and the presence of other symptoms like cramping, nausea, vomiting. We do tend to get imaging if it's grade 3 or more, including a CT scan, or with the GI team, we would get an endoscopy and colonoscopy. This is the grading for diarrhea and colitis on the bottom. So grade 1 would be less than 4 stools per day over the usual frequency for patients. Grade 2, we would hold treatment generally if they're on combination treatment, and kind of keep a close eye, maybe delay treatment a week or so and see how things play out. Grade 3 or 4, we do hold treatment and we start corticosteroids pretty quickly. And if people don't respond to steroids, systemic steroids, we do tend to add on another drug called either infliximab or vedolizumab to help control the colitis when we need to. So this is a kind of a nice little chart that we can use for like grade 1, so it's supportive care, use Imodium if needed. You do want to push fluids, make sure people aren't getting dehydrated, and we tend to recommend avoiding like red meats, dairies, fresh fruits and veggies in the short term to kind of give your gut a rest. If it's prolonged, we do tend to get a GI consult involved. For grade 2 or 3, it's going to be hold immunotherapy and evaluate further with scans or scopes, and start steroids when appropriate. Hepatitis, so inflammation of the liver. We screen for this, but we get liver function tests prior to each dose of immunotherapy. If we start to see the liver function tests start trending up, we do tend to get it more often, sometimes weekly, to see how things are progressing. Most patients who have hepatitis from immunotherapy are asymptomatic. We tend to see these changes on the blood work only. However, some people will say, oh, I do feel tired, I have some abdominal bloating or discomfort. And uncommonly, we can see some jaundice, so yellowing of the eyes or the skin, but that's pretty uncommon. We do want to rule out other drug or viral-related causes, get imaging such as an ultrasound if indicated, and do a viral hepatitis panel to make sure this isn't a viral activation of hepatitis instead of an autoimmune process. If we start seeing the liver function test uptrend, we do recommend holding acetaminophen to avoid additional stress on the liver. And we also advise against alcohol during immunotherapy treatment, particularly with the combination treatments where we can see more hepatitis. We can see this in about up to 10% of patients getting monotherapy, but about a third of patients getting combination of IPI and Nivo will develop some level of inflammation of the liver. About 15% of those will have a grade 3 toxicity. This is usually within the first 3 months of treatment. And the grading is based off of the lab values. So if the lab values are 5 times the normal level, that's when we start steroids. If they're grade 2, which is 3 to 5 times above the normal level, we tend to hold treatment and see and kind of trend labs pretty closely and to start steroids if it's continuing to elevate. Steroids, again, are the gold standard for immunotherapy side effects and no different in the hepatitis. And if we have any complications, we do get the hepatology or the liver team involved if necessary. For people that don't respond as well to the corticosteroids, there's a second agent that we can add called mycophenolate, which helps reduce the inflammatory response in the liver and helps us get patients off steroids. But again, this is about 4 to 6 weeks of steroids when indicated. So if we taper too quickly, we can see the side effect come back or kind of rebounds. So we do it slowly. And infliximab, which I mentioned with the colitis, we use for patients that are refractory to steroids. We do not use it with hepatitis because of the concern for liver toxicity. Instead, we would use the mycophenolate. Pneumonitis, inflammation of the lung, happens about 5% of patients on PD-1 drugs. Patients usually can present with a new cough or worsening coughs and new shortness of breath. Decreased oxygen levels on the pulse ox, and possibly some fevers. This can be a little bit tricky to diagnose. It can be confused with pneumonia. It can look pretty similar on imaging. And if we have any concern whether this could be an infectious finding versus a side effect from treatment, we do get pulmonology involved to do a bronchoscopy. The incidence of pneumonitis in the single agent PD-1s ranges about 5 to 7%, so pretty uncommon, but we give a lot of immunotherapy, so we see this quite a bit. Grading is here. So grade 1 would be asymptomatic. We got a CT scan for restaging purposes, and we see some inflammation of the lungs, but there's no symptoms. We can still give immunotherapy. We might consider holding it at least temporarily and see how things play out. Depending on the pulse ox, depending on the symptoms, we might do a repeat scan to kind of keep a close eye. But technically, we can still treat, but we do keep a close eye in case we cause the pneumonitis to get worse with further treatment. Grade 2, or grade 3, we tend to hold the immunotherapy and start steroids. And once symptoms recover to grade 1 or better, taper prednisone over 4 to 6 weeks. Again, I said this is pretty uncommon, but we see it quite a bit given the frequency that we give immunotherapy at Georgetown. We do get a pulse ox every time we see patients, just to make sure we have a good baseline. And we have a low threshold for doing imaging on someone that has a new cough or any shortness of breath. We would at least get a chest X-ray, if not a CT scan. The picture you see here, your lung is supposed to be nice and black on the imaging, but these white infiltrates that you see can indicate pneumonitis. They can also kind of look similar to a pneumonia. So sometimes we, if you present to an ER and they diagnose a pneumonia, we tend to kind of weigh in and say you got to think about pneumonitis as well, because it can be a little bit tricky to diagnose. So this is I think I already went over this as far as when to start steroids with pneumonitis. So those are the more common immunotherapy side effects that I wanted to review today, just because those are ones that we're going to ask about symptom-wise at every visit. And while not immunotherapy, I did want to kind of touch on the side effects that we see with the BRAF and MEK combination, as Dr. Atkins had talked about earlier. So with the BRAF drugs, we have 3 different combinations that are approved, but we can see fevers and fatigue quite a bit with the BRAF drugs, and also a lot of skin toxicities like rash, photosensitivity, itching, some non-melanoma skin cancers can develop. So we do want patients on the BRAF drugs seeing dermatology closely to evaluate for that. And also with the MEK inhibitors, you can see it's a different appearing rash, but while we can see skin toxicities with both of these drugs, in combination, we actually see less skin side effects when we use the 2 drugs together as opposed to using them independently. We do get lab work on all of our patients whenever we see them to evaluate for any lab abnormalities like liver findings. And for patients that are on the BRAF-MEK combinations, we get routine cardiac evaluations like echocardiograms to assess for any decreased ejection fraction or any changes in your heart's ability to pump blood. And that's usually every 3 to 6 months. And then here are the 3 approved drug combinations and just some of the kind of pros and cons to each. But with the Dabtran, we see a higher rate of fevers. But we do manage side effects with the BRAF-MEK drugs differently than we do with immunotherapies, because this is not an immune response causing the side effects. Usually a drug hold is sufficient. And then if you have fever, starting like acetaminophen or ibuprofen would be indicated in the short term. With the VEM-CoV, we do see a higher rate of photosensitivity. So patients on these drugs need to be very careful in the sun, using good sun protection, sunscreen, the UV shirts. And then the ANCO-BINI, we do see lower rates of both the fevers and the photosensitivity. So that was just a really quick synopsis of the BRAF drugs. But in summary, the key to toxicity management is communication with your team. We always tell patients that we want to hear from you. We'd rather hear from you than not. Even if it's minor, reporting side effects in between visits is important, so we can kind of determine if we need to see people sooner than they're scheduled or intervene faster. Again, side effects can happen at any point during or even after treatment. So people can be off drug for several months and still get immunotherapy related side effects. It's easier to treat toxicities early. They do resolve quicker with early interventions. It's important to report these things so we can intervene when necessary. And again, the majority of these side effects are reversible with appropriate management. Some of the endocrine abnormalities or endocrinopathies, it's more of a long-term issue, but usually pretty easy to manage with appropriate drugs. And then depending on toxicity, treatment may be restarted depending on time to improvement and how well you responded to the corticosteroids. So again, notifying your team of any new or worsening side effects, even if mild, is going to be key. And I think that's all I have.